Alright, let's dive into sleep disorders. So, the most shocking thing for me about sleep is how little we actually know about it and how little we know about something that we spend a great deal of time in our lives doing. So, with that said, let's go through a little introduction on sleep and talk about the basics. First of all, sleep is restorative. It's very routine. It warrants little thought. Most people don't, and unless you have a problem sleeping, of course, think about, what their process of going to sleep. You just kind of reach a certain point in the night, you lie down, and you fall asleep. At least that's the way it should be. However, when this process is disturbed in any way, it can actually impair all facets of daily life. So you can have some cognitive difficulties, you can have some difficulties, remaining awake during your workday. So there's a lot of problems that can happen if your sleep is indeed interrupted. In this presentation, I'm going to go over some detail about normal sleep. Not too much, but just some basic stuff about normal sleep, the stages, the cycles, the rhythm, the biological mechanism, etc. Things that are kind of testable points for anybody who's in psychiatry or neurology or in medicine in general. Sleep is a big deal. A lot of what we get people to do in psychiatry is we need to get them to sleep. So that's where the idea for this kind of information comes from, and why it's important to you in clinical practice. So with that said, let's talk a little bit about the history, because you never know when a question is going to ask you about some stupid history thing. But anyway, the quest obviously to understand sleep is as old as mankind. Anyone who's going through the process might ask the question, why do we sleep? Seems like a very reasonable thing. But the reality is we haven't really learned very much about sleep until the last 70 years. So in the last 70 years, we started figuring things out a little bit better, but still haven't quite sorted it all out. During this time, sleep was redefined over that 70-year period as an active state. So it used to be thought of more as a passive state. Now it's seen as an active state. It has, of course, stages and cycles and rhythms, and it's as complex as the waking state. So that's important. I mean, it's almost as complex as being awake, which is, again, kind of shocking. You don't really think of it that way. In 35, they observed that EEG changes are prevalent throughout sleep. So this is where the idea of attaching EEG electrodes to the scalp during a sleep study or polysomnogram would be a smart move, right? Because we can observe changes in brain activity. Now, in 53, they detected various types of eye movements during sleep. So this was the first time they started realizing there's some component of eye movement that goes on in the different stages of sleep. So most notably, they had the slow rolling eye movements, which were occurring during early sleep and disappearing as sleep progressed, and the rapid eye movements associated with irregular breathing and increased heart rate. So what they did was they named the sleep phases associated with slow rolling eye movements as the non-rapid or non-REM sleep, and the phase with the fast erratic eye movements, that was named REM sleep or rapid eye movement sleep, right? And then in 55, what happened was we discovered that REM sleep was associated with dreaming, so that's kind of important. You see you have dreams during REM, make that connection right now. And 2 years later, they discovered that REM and non-REM cycled over the course of the night. So you actually go through multiple cycles of REM and non-REM, and it's kind of a process, and we'll talk about that in the future. So what about this polysomnography or sleep study? Well, this is our method, if you're a sleep specialist, for objectively evaluating sleep. And what you would do is you would have a patient come in, you would attach them to a bunch of monitors, and you would simultaneously record multiple physiological variables in a standardized fashion, of course, because we're scientists. And that would be known as a polysomnogram. The parameters recorded in this sleep study are the following, but not necessarily limited to these, would be an EEG. Like I said, we observed in 1935 that there were changes in the EEG during sleep. So why not record electrical activity of the cortical neurons via scalp electrodes? And they would be placed in this so-called standardized position according to the International 1020 system. That I have a diagram in the next slide, so I'll go over a little bit about this International 1020 system. Really nothing to memorize, nothing to know, because you as the doctor will most likely be ordering these kind of tests, but not necessarily attaching electrodes to people's heads. Now, the next thing to talk about, of course, is the EOG, which is going to the electrooculogram, which will record your eye movements. So, like we said, they discovered that in 1955 or so that there's some eye movements that go on, and there's these slow rolling eye movements that happen during non-REM, and this more rapid erratic movement that happens during REM sleep. So, of course, we want to record that. You want to record an EKG monitor because we want to look at the heart rhythms. You want to have an EMG or electromyogram because we want to look at activity. Particularly, they usually only record in a couple of spots. One is the left and right tibialis, and the other is the anterior muscles and the submental chin muscle. So movement of the chin, because people might do teeth grinding or bruxism or something along those lines. So we want to have that going. Respiratory effort as well. So there'll be a pulse ox attached, and there'll be a microphone attached to the chin for the snore monitor, because a lot of people who go for sleep studies are going because they may have sleep apnea. And so you want to know, is that person, snoring a lot, and what's going on? So that's another thing that they're testing. Those are most of the things. By employing this, we can kind of see, we can separate out the process. We can see wakefulness versus sleep onset versus non-REM versus REM, and it can be defined, studied in an objective manner, which is what we do as, again, scientists and physicians. So here's the basic layout, just to give you an idea of what all that stuff looks like attached. There's a stock photo of this gentleman who looks way too comfortable wearing all of these things. So that's what it would look like if you were to come in for a sleep study. I don't think it would be in such a bright room, but that's pretty much how it would go down. And the other diagram there is just quickly the International 1020 system. Nothing special, just kind of shows you where you would want to attach those electrodes and sort of where each of those electrodes is recording what part. Is it occipital? Is it frontal? Whatever. Right? So just some things to be aware of. I'm going to cut it here on this video. The next one we'll start diving into the stages and such. But I think this is a good place to kind of leave the introduction.